Welcome to Mount Elizabeth Hospital's Annual Medical Seminar 2021, jointly organized by Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital. The theme for this year for the webinar is Living with COVID-19 Endemic and the Road Ahead. A very good afternoon, ladies and gentlemen. My name is Charlene, your MC for today. This is the second year that we are bringing our annual medical seminar online. We are excited to have a lineup of 6 speakers to present on a wide range of topics and privileged to have with us Dr. Leong Ho Nam as our moderator for our 2 sessions of the panel discussion, 1 and 2. Now, each session will have 3 doctors and a 5-minute Q&A that is open to the floor. Before we start on today's first session, some reminders on what to do. On your screen, there is a Q&A section, and you can type your question in. So once your question is approved, it will appear under the live questions list. For doctors who have logged in with your registered account to watch the live stream today, Mount Elizabeth Hospitals will submit your attendance to the SMC and SDC. Ladies and gentlemen, if you encounter any technical difficulties, please contact us. And of course, our contact details are found on the bottom list of the website. And our crew will be on standby to assist you. At the end of the session, please also help us by filling up the feedback form. Your suggestions and feedback will help us to improve our future event. Just a gentle reminder that the URL is case sensitive when you type in on the browser. Last but not least, ladies and gentlemen, we would like to thank our sponsors for the event and also our co-sponsor, Sandoz. Without further ado, ladies and gentlemen, let us now commence on the event with our welcome address by our Mount Elizabeth Hospital Chief Executive Officer, Mr. Yong Yih Ming, followed by the opening speech by Dr. Richard Fan, CME Chairman of Mount Elizabeth Hospital.
Dear friends and colleagues, together with Dr. Peter Chow, CEO of Mount Elizabeth Novena Hospital, it is our pleasure to welcome you to the 2021 edition of the Annual Medical Seminar jointly organized by Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital. This year, it is our honor and privilege to have Dr. Richard Fan and Dr. John Chia, our respective CME chairmen, to co-chair the AMS. We are still very much in the midst of the COVID-19 pandemic now. However, we have accumulated over 20 months of collective wisdom and experiences to discuss how we can coexist with COVID-19 and evaluate what could be next for all of us in this sustained fight. It is with this backdrop that we decided on this year's theme of living with COVID endemic and the road ahead. It is with pleasure for me now to hand over the proceedings to Dr. Richard Fan for the opening address. I wish everyone a fruitful and enriching annual medical seminar.
Dear friends and colleagues, it brings us great pleasure to welcome you to the Mount Elizabeth Hospital's 2nd virtual annual medical seminar, jointly organized by Mount Elizabeth Hospital, Orchard, and Mount Elizabeth Novena. With the new norm brought on by the pandemic, we will be holding this year's annual seminar virtually for the 2nd time under the theme Living with COVID Endemic and the Road Ahead. The pandemic has upended the world and underscored the importance of combining sound scientific knowledge and strong socio-economic policies. Even as the threat of acute COVID is being addressed with vaccine boosters, effective oral antivirals, and increased bed capacity, scientists are raising the alarm on the specter of long-haul COVID, which will consume healthcare resources for many years to come. Our focus for this year's seminar is to help doctors operating in our healthcare systems adapt to the transition of needs from acute to long-haul COVID. I would like to thank my co-chairman, Dr. John Chia, from Mount Elizabeth Novena Hospital, for his invaluable input in the scientific program. Mr. Yong Yih Ming, the CEO of Mount Elizabeth Hospital, and Dr. Peter Chow, CEO of Mount Elizabeth Novena Hospital, for their support. Ms. Ho Man Yi, for her hard work and energy in getting the speakers and fine-tuning the program, and our dedicated marketing team for their contribution. To the sponsor, our deepest appreciation, and to all participants, thank you for taking the time to join us at the webinars and we hope that you will get great value in the sessions and enjoy the new virtual experience made possible as we continue to innovate and overcome challenges and stay ahead in this age of disruption. Together we can overcome this pandemic. It's possible.
Our first speaker is Dr. Barnaby Yang, an infectious diseases consultant from the National Center for Infectious Diseases. He's also the principal investigator for several large clinical studies during this COVID-19 pandemic. Now he'll be speaking about long-haul COVID, healthcare in a post-COVID world. Ladies and gentlemen, let us welcome Dr. Yang, please.
Good afternoon. I'm Barnaby Yang. So I'm one of the infectious diseases consultants at NCID, and I'm going to be talking about long COVID and the research that we've been doing at NCID since the beginning of the pandemic to understand some of the aspects of long COVID, and then also talk about a new clinic that we've established at NCID to help investigate and diagnose and hopefully treat people with long COVID. So just a quick bit about my disclosures. None are directly related to post-acute COVID syndrome, which is what we'll be calling long COVID. So an overview, as mentioned, I'll be talking about what is post-acute COVID syndrome, providing some local data from the PROTECT study, which is one of the main studies that we've been conducting at NCID to understand acute COVID and also post-COVID complications. And then finally, talking about the NCID post-COVID clinic. So the case definition for long COVID, we're adopting something that was developed in the UK by NICE, which breaks up the COVID syndrome into early, middle, and later phase. So acute COVID-19, generally considered to last for up to 4 weeks. Ongoing symptomatic COVID, signs and symptoms of COVID, which persist for 4 to 12 weeks. And then post-COVID syndrome is signs and symptoms that develop after that period. And there's several different ways that that can manifest. It may be that people continue to have symptoms from their acute illness, or it may be that they develop new symptoms, or that those symptoms are fluctuating, waxing and waning. Sometimes we can think about post-COVID syndrome developing earlier in some individuals, but generally once the patient has reached 12 weeks, that's where we would consider this to be a post-COVID syndrome. And this is broken down very nicely in this paper from Nature Medicine, which summarizes both the acute and the post-acute symptoms and viral replication associated with COVID. So PCR positivity with COVID from the nasopharynx usually persists for 3 to 4 weeks after an acute infection. And it may also be able to be cultured for the first week or so, maybe up to 2 weeks, which is the purple line there in patients who have acute COVID. And then afterwards, there is a multitude of different symptoms that people have reported associated either with that post-acute phase of COVID, that early phase between 4 to 12 weeks, or a post-acute COVID after 12 weeks. And it is extremely perplexing as to what exactly is going on. And this was a summary taken from a post-COVID webinar earlier this year by Professor Altman, who summarized some of the different hypotheses there are about what may be going on. So whether it may be residual damage to tissue, particularly ACE2 positive tissue, which is where we expect the virus to have infected. It may be that there is ongoing immune stimulation, so these viral fragments which are present within the nose and potentially within other tissues or organs such as the gut may be continuing to drive some immune activation. It could be just a consequence of the acute infection resulting in long-term change to the way that the immune system is functioning, or perhaps activating an autoimmune response. What makes this extremely complicated is that there's very much overlap between the cause and the effect of the post-COVID syndrome. And we can think about it as three major groupings. The severity of the infection, so the severity of the acute COVID illness, clearly has an effect on the likelihood that someone will develop long COVID, though also it is not necessary that someone has a severe infection for them to develop long symptoms. Somewhat related to viral replication, and we expect that in people who have a more severe illness, more virus will be present and may be present in more tissues than someone who has a non-severe infection. And of course, both the severity and the viral replication are influenced by the immune response to infection. And there are multiple areas at which the immune system acts on the virus and can result in long-term symptoms from someone who is recovering from an acute illness. So the studies which I'm going to present come from the PROTECT study, and this was a file draw protocol that we developed at NCID, or CDC as it was back then, in 2012 by my seniors. And this was a protocol to help us be able to respond to emerging infectious diseases in Singapore, to be able to get in and do those important studies, particularly early during the pandemic or during an outbreak, where we don't have the luxury to sort of spend some months developing a protocol. So this PROTECT study protocol was first used for a couple of outbreaks, but fortunately, since 2012, we hadn't had a large outbreak of the scale of COVID-19 to really test drive it and work out how to operate it. The study is a collaboration between all of the public hospitals in Singapore. Sengkang has joined us as well, and patients are recruited usually during their acute illness. Early in the pandemic, we were collecting a lot of different samples, respiratory samples, tears, stools, urine, in order to assess where the virus was replicating and how long PCRs may remain positive. We also collect blood, we collect clinical data, and earlier in the pandemic particularly, there were some studies looking at environmental transmission, so where the virus is present within a patient's room, or on people's the clothing or the PPE of health workers. And as well as being a collaboration between all the public hospitals in Singapore, most of the academic institutions are also involved. Our main collaborators have been at Duke NUS, Prof. Lim Fa Wang, and then at A-Star ID Labs with Prof. Laurent Regnard, who's now joined LKC Medicine, and Prof. Lisa Ng. Our first papers were really understanding about the acute infection, understanding the clinical patterns of disease. But we continued to follow up people who had joined our study in order to understand how the immune system was evolving, actually up to 2 years after the diagnosis of COVID. And this paper, published earlier this year, analysed the results from people who have been on follow-up with us for 6 months. So we had recruited 288 participants at that point, and we have follow-up data up to 180 days for 120 of them. And we were particularly interested in looking at which people continue to report symptoms related to COVID-19 and understanding which people had inflammatory abnormalities. So that was particularly the presence of inflammatory cytokines in their blood. And we saw from this cohort that approximately 10% of patients who had recovered from their acute illness had persistent symptoms out to 6 months. And there were significant abnormalities in the levels of these inflammatory cytokines. I'm not going to go through exactly what those cytokines do because that is extremely complex. But there were certainly abnormalities, and those abnormalities were present in people who had symptoms and in people who did not have symptoms as well. In terms of which patients were most likely to develop persistent symptoms, we found that it was most likely in people who had had a severe infection. And most of the other findings on this table here relate to those people who are most likely to develop severe infection as well. So older age being of course significantly associated with severe infection, being male, and having more comorbid illnesses. And this is the summary of the significant cytokine differences that we detected. So in the top we have a heat map, which extrapolates out some of the significant cytokine markers that we detected at these time points post the acute illness. and demonstrating then in the chart on the bottom left that there was a grouping that we could separate out individuals based on the severity of their illness to see different patterns of the cytokines for these individuals. And subsequently, we went further to try to understand perhaps where these cytokines were coming from, or what the effect of some of these cytokines may be. And this was a paper led by Christine Chung from LKC Medicine, which was looking at circulating endothelial cells. Inflammation, such a critical part of a severe COVID illness, and that inflammation is systemic, so not confined to the lungs, as I believe we'll also hear very much from speakers who are talking today about the effects of long COVID on other organs. And in particular, we saw that people who had pre-existing cardiovascular conditions, or pre-existing conditions which are associated with risk factors for cardiovascular disease, have more pronounced endothelial activation than people who had never had COVID before. And in particular, there was this inflammation was associated with circulating endothelial cells, which is what is demonstrated on the chart there on the left. And then on the right, we're just extrapolating out that there was more evidence of inflammation in people who had more cardiovascular conditions. So the big question is, why does this happen? I think that long COVID is associated with some degree of inflammation, is fairly clear. The question is what is driving that inflammation? And for anyone who's looked after someone with acute COVID, the persistence of the virus in nasopharyngeal swabs, at least when detected by PCR, is quite extraordinary. The fact that we will sometimes see a positive PCR even months after a diagnosis. It's only at very low levels. We're not able to sequence a whole virus. We're, of course, not able to culture the virus, but fragments of the virus can be detected by PCR. And this is shown in this study here with the chart on the right there showing the positive PCRs even up to several months after a diagnosis of COVID-19. This is just a messy summary of another hypothesis that part of the reason why we're detecting parts of the virus for so long is because SARS-CoV-2 may be able to integrate into the host genome. This is an extremely controversial hypothesis, very interesting to consider from a scientific point of view, but the evidence probably stacks up that this is not likely to be the case. And it is something else which is driving the persistence of inflammation. And one hypothesis which I think is very interesting, and this is a study from Hong Kong, is looking at microbiome changes which are associated with long COVID or associated with the severity of an acute COVID illness. So in this study from Hong Kong, the investigators collected microbiome samples early during the course of acute COVID and then correlated that with the severity of the disease. And they saw very clear evidence of different microbiome patterns early in the illness, and that those microbiome patterns were different depending on differed based on the inflammatory markers that were detected subsequently. So on the left, they correlated the microbiome with different cytokine levels. And in the second chart there, they correlated microbiome with inflammatory markers that we routinely measure in clinical care, such as CRP and ESR. So this is an interesting hypothesis, I think, and suggests that perhaps some treatments for long COVID, perhaps even some treatments for acute COVID, may relate to adjusting the gut microbiome with probiotics or prebiotics. And Prof. Ang is conducting a clinical trial of this in Hong Kong at the moment. I can't give a conclusion to this at the moment as to what exactly is triggering long COVID. So I'm going to move on to talk about the range of different symptoms that can be associated with long COVID and the different sorts of assessments and investigations which are necessary to diagnose the condition and to work out what to do next. So this is a paper from the BMJ, Trish Gillenhall, and it summarizes the multi-system consequences of long COVID. So it's not just a pulmonary condition, it's a condition which is associated with abnormalities in pretty much every single organ. And so finally, perhaps at NCID, we have established a post-COVID clinic. We just started a couple of weeks ago in November of 2021. We have a fortnightly clinic at the moment on Friday mornings at Clinic J and NCID, and myself, Dr. Darius and Dr. Stephanie from NCID are seeing patients who are referred to us who have symptoms suggestive of a post-acute COVID syndrome. We're focusing on adults, and we are particularly looking at people who meet the NICE clinical case definition for post-acute COVID syndrome, so greater than 12 weeks after a confirmed or presumed COVID-19 illness, and people who present with persistent or new symptoms, which is thought to be related to that. We sometimes see patients earlier as well. 12 weeks is, of course, a rather arbitrary cutoff. So on a case-by-case basis, we may see people earlier. And with the movement to endemic condition in Singapore, we accept that some people may not have a diagnosis of COVID confirmed by PCR. It can be difficult to confirm the diagnosis by serology if they have been vaccinated. So we'll also see people with ART or a clinical suspicion of prior COVID. And the aim for this clinic is to be a hub for the patient in a sense. So we want to, I think a lot of people can feel lost when they're diagnosed with long COVID, or if they think they have long COVID, they don't know where to go and they don't know who to see. And so we want to be a centre for them where they can come and see us and we can provide the initial assessment and then onwards referral to specialists as required. And we have a network of specialists from all different disciplines within Tan Tock Seng Hospital who are helping to advise us how to run this clinic and will be points for onwards referral. So in the clinic, we assess, it's fairly straightforward really in some ways, a detailed history and examination, assess the symptoms in a structured manner. We perform a post-COVID functional status score and if necessary also assess for anxiety or depression. We do some routine lab tests, some imaging and an ECG. And the PCFS scale, post-COVID functional scale, score scale, is something that we use to assess the impact of the symptoms post-acute COVID on the person's functional status. Lab tests, nothing fancy. We're mainly wanting to make sure that we're not missing something obvious that may be the explanation for the symptoms. So we screen for blood count, electrolytes, liver tests, inflammatory markers, thyroid and vitamin levels, mainly B12 and folate, and sometimes vitamin D. We don't have a panel at the moment. What we would like is to have a blood test where we can assess somebody's cytokine levels, relate that back to their symptoms and be able to tell someone, yes, you have acute COVID, yes, you have post-acute COVID, and this is sort of how we're going to classify the illness, but we can't do that, despite what some people online suggest may be possible. So instead, we do this basic assessment, and then we look at the symptoms and decide where to go next. So yes, the aim of our assessment really is to confirm the diagnosis. So to be able to tell someone, yes, we think you do have a post-acute COVID, and if possible, identify relevant organ changes which can be referred to a specialist for further management, and principally that has been residual pneumonitis. We don't offer treatment routinely because we don't really have anything. We would offer advice, information, reassurance, and where possible, interventions. We provide symptom relief, and of course we would ask people to get vaccinated for COVID if they have not received the primary series vaccination already, and if they have received, to get their booster. And finally, we intend this to be something that we can use to help develop new diagnoses, new ways of diagnosing COVID, and also a way of testing different therapeutics so that we can sort of find a solution in the end. And the patients that we've seen so far in the clinic have all been very eager to contribute to this, to understand their own condition better and to be able to help other people who may be suffering from the same symptoms. So finally, many people have been involved in the studies. I've obviously just briefly touched on some of them as part of the PROTECT study, and most of the public healthcare institutions and academic institutions in Singapore. I'd just like to also thank the SCRM fellows and research assistants who've put in a lot of time, along with the nursing staff, particularly at the hospitals, to help us collect samples and recruit patients and follow them up. And finally, it's always difficult when someone's unwell in hospital for us to then come up and ask them, can we take some more blood? Can we take some more swabs? And so I'd like to thank all the people who donated their clinical samples to us. Thank you very much.
Thank you so much, Dr. Yang. Next up, we have Dr. Kenneth Chan, a respiratory physician and intensivist from the Mount Elizabeth Hospitals, specializing in general respiratory medicine. Dr. Chan also has subspecialty interest in intensive care and bronchoscopy. He will be presenting on the topic long-term COVID effects on the lung, mitigation and management. So let us welcome Dr. Chan, please.
Good afternoon and welcome to the annual scientific seminar, and thanks to Mount Elizabeth Hospital for inviting me. My name is Dr. Kenneth Chan. I'm a respiratory physician, and I've been tasked to talk to you a little bit about the long-term effects of COVID on the lung. Okay, so first up, and this slide is already a week old, but up to a week ago, unfortunately, COVID-19 has become the most important healthcare emergency globally. And up to a week ago, there are now about 260 million cases and 5 million deaths, of which about 10% of these cases would end up being hospitalized and cared for. What we now know about COVID-19, and as you have heard from the previous speaker, its effects actually persist beyond the hospitalization. And this is data that's just fresh out from a cohort in Florida of about 14,000 patients. And these cohorts, the observations were started after they were discharged from the hospital. And the blue line represents patients who are hospitalized with COVID, and the red line represents mild COVID-19 patients that were either treated as an outpatient or at home, and then they had also a control data set which is in the red line. And what you could see here, even after discharge and over the next 12 months period, being hospitalized with COVID continues to confer an increased mortality risk, and patients continue to have an excess death as compared to patients with mild COVID or even no COVID at all. What is kind of surprising in this data set is only about 5% of these individuals eventually have their mortality attributed to a respiratory or a cardiac cause. So it's actually something else. But this is a fairly preliminary paper, and they did not describe the actual causes of death. And I'm sure there'll be more papers that will be coming out from this particular cohort. So back to what I was saying, of the 26 million hospitalizations, it is estimated that 3/4 of them actually have frank pneumonia from COVID, of which a third of them will have severe lung manifestations leading to the acute respiratory distress syndrome. And even conservatively speaking, up to 13 million may be left with fibrosis and potential long-term reduction in lung function. And hence, even after acute COVID, there is potentially another epidemic that will now go on. So I'm going to talk about today about the risk factors of pulmonary fibrosis, what are the long-term implications on lung function, and finally, do we have anything in our armamentarium right now to try and prevent this sequelae from actually happening? What we do know is the risk factors for pulmonary fibrosis is not dissimilar to many patients with pneumonia or severe pneumonia. Age is a risk factor. Severity of illness is a risk factor. So if you are you are admitted to the intensive care unit or you're very oxygen dependent, that puts you more at risk of developing pulmonary fibrosis. And the other risk factor is obviously if your lungs are already activated in the form of an external inhalant such as smoking, that again puts you at risk. What I'm about to say though, I have to say is we don't really have a lot of long-term data from a respiratory sequelae standpoint. So what I'm about to say is partly extrapolated from our experience with similar coronaviruses. And everyone here will be familiar with the SARS epidemic in 2002 and 2003, of which 10% of patients died and 90% were survived, but many were left with sequelae. And of course, the Middle East respiratory syndrome, which is still ongoing. This is a fairly recent paper in preprint where they did a systematic review looking at post-viral parenchymal lung disease and viral pneumonitis. And in this review, they took all observational studies that included respiratory viral pathogens. And these included SARS-CoV-1, SARS-CoV-2, MERS, and even influenza pneumonia, who were followed up to 12 months from discharge. And not surprisingly, on follow-up CT, easily up to 40% of them had fibrotic findings. Some still had inflammatory findings. And when spirometries or lung function tests were run on these patients, about 20% will have lung restriction and 40% will have a reduction in diffusing capacity. Meaning in spite of a lack of imaging changes, the ability of the lung to exchange gas, to bring in oxygen into the body remains impaired. When they looked at the cohort of patients with SARS-CoV, and I will just remind everyone that we don't really have a long-term data at the moment. The longest data set after discharge from the hospital was COVID. It's about 3 months. About 43% had inflammatory change and 30% had fibrotic findings. And in another systematic review that was published about 3 or 4 months ago, consistent with the previous paper, the lung function were impaired. About 40% had altered diffusing capacity. But interestingly, the forced vital capacity was largely preserved in this particular cohort. And those that had a reduction in forced vital capacity, most of these changes were actually mild. What about SARS? And the reason why I'm showing this slide is what we are seeing in COVID-19 is similar to SARS. This is our own Singapore data set of 46 survivors of SARS, and again, consistent with the previous slide, 15% had mild impairment in forced vital capacity, and about 40% had mild reduction in diffusing capacity. But this did not seem to translate to preserved exercise tolerance. And when these patients actually underwent a very formal way of assessing exercise limitation in the form of cardiopulmonary exercise testing, a good number of them had impairment in exercise capacity, which was not due to ventilatory limitation. So not due to the fibrosis or any scarring in the lungs per se. There had been a number of postulated causes. Many survivors of ICU care or ARDS have impaired muscle function, either because they have received medicines that negatively impact muscle function, just like steroids, for example, to this condition called critical care myopathy, also known as ICU acquired weakness. And of course, they're all deconditioned after spending weeks to months bedridden and trying to recover from a severe pneumonia. So those are some of the postulations leading to a limited exercise capacity. What happens to SARS survivors 1 year out? So this cohort is from Hong Kong rather than Singapore. Again, fairly similar observations, but what's gratifying to know, as you can see, the number of individuals with reduced forced vital capacity dropped substantially to only about 4%, and there is also a reduction in the number with a diffusing capacity impairment. And this is actually similar to our own experience here, in that the lungs do actually heal. Okay, so I'm just showing you an X-ray of an 84-year-old patient of mine with severe COVID, and he was really sick. He was in the ICU. He had multiple organ failure requiring inotropes, dialysis, and the first X-ray that you see here is the X-ray on discharge, and what you could see is there's still extensive infiltration bilaterally, primarily in the peripheral and basal distribution. And I'm still following him up. This is what his X-ray now looks like 1 year down the road. And you can see, other than maybe some subtle linear reticular opacities in the left lower lobe, most of the lung has actually healed. This is, again, not COVID, but more data from SARS. And this is actually a cohort from China, okay, of 71 patients. And they followed up their patients. This is literally 15 years later. And the slide is a little bit busy, but what we are trying to depict here with this figure is that most of the improvement on lung injury, on CT and pulmonary function was actually just in the first 2 years. And subsequently, you can see those that did not improve, or after that improvement, it actually plateaus. Right, so what we can say is, if you have severe COVID or hospitalized COVID, there is a good chance that lung function will be impaired for a short while. But on actual measurements, this tended to be mild, and it seems that it is out of proportion to impairment in their quality of life and their exercise tolerance. And whether that's to do with ICU-acquired weakness, whether it's to do with steroids, and maybe this aligns well with Dr. Young's data, where it seems that a pro-inflammatory milieu in the body continues to exist even after COVID-19. In the next section of my talk, I'll just spend a few minutes talking more about can we do anything to mitigate respiratory sequelae or to prevent the fibrosis. There's very little out there, understandably so. Obviously, COVID-19 is a new illness to us. But what we do know is if we can prevent severe illness, prevent patients from becoming oxygen dependent and going on to hospitalization, that in itself will probably lead to less respiratory sequelae. So we all look forward to the oral medicines that has been in the media recently, molnupiravir as well as Paxlovid from Pfizer. And of course, what's already available are the monoclonal antibodies for high-risk patients. Of those that are already hospitalized, especially if they end up in the intensive care unit, what is probably important is any therapeutic interventions that we need to try and protect the lung as much as possible. So while some of these interventions are life-saving, there's actually good evidence now that For example, if we are over enthusiastic with mechanical ventilation, we will end up injuring the lungs even more. So appropriate mechanical ventilation. I'll talk a little bit about steroids, and I think since a number of trials, including the recovery trial by the World Health Organization, anyone who has oxygen dependent or who is severe COVID, dexamethasone or its equivalent has been shown to mitigate the lung injury, enhance recovery, as well recovery from COVID. What I want to point out though is that we are now increasingly observing a subset of patients where the mechanisms of lung injury and inflammation actually changes. So this is another of my patients, and he came in just about 8 months ago to me. As you can see, he had very bad COVID, and he actually required intubation. And after intubation, we also started him on steroids. And you can see by day 6 of steroid, about 3 days after intubation, there is actually substantial improvement in the infiltrates, enough so that we were already thinking about liberating for mechanical ventilation. At that time, because markers for inflammation such as the CRP, the white cell count, etc. were fairly low, we started tapering the steroids. And lo and behold, about 5 days later, it ended up with recrudescent disease. And you can see the infiltrates, the oxygenation, etc. worsening again. And we had to defer extubation, and we had to actually escalate the steroids. And the point of this slide was to now create some awareness on the emerging entity of organizing pneumonia, which is, in a sense, you can again think of it as an inflammatory response to the COVID-19 COVID virus that is actually quite steroid responsive. And in these individuals, unlike the recovery protocol for steroids, we actually need to keep them on a lot longer and taper quite slowly. So in this particular patient, I had to taper the steroids over about a month or so. Finally, I'll talk a little bit about antifibrotics. So if the respiratory sequelae consists of pulmonary fibrosis, it then makes sense to think whether there are actually medicines out there that can mitigate this fibrotic process. And of course, this is kind of something that a lot of doctors start thinking about, because we do have antifibrotics available, but for a different entity, okay, for other kinds of progressive pulmonary fibrosis. Mechanistically, it may make sense, okay, so typically in many forms of lung inflammation, it is the transforming growth factor signaling pathway that comes into play. And again, without going into too much detail about this particular slide, that leads to activation of a number of the cytokines you have already heard about in the previous, from the previous speaker: hepatocyte growth factor, vascular endothelial growth factor, which leads to myofibroblast activation, matrix deposition, and pulmonary fibrosis. So we've been looking at mesenchymal cells, stem cells, for a long time, not just for influenza pneumonia, but for many forms of ARDS. And of course, there's now nintedanib, which is a tyrosine kinase inhibitor, that's been kind of well shown together with pirfenidone, both of which acting on different parts of the pathway, as you can see in this particular slide, actually preserves lung function and controls pulmonary fibrosis, or at least prevents pulmonary fibrosis from worsening in other forms of pulmonary fibrosis, such as usual interstitial pneumonia, or a fibrosing form, fibrosing variant of organizing pneumonia. Having said all that, in these particular antifibrotics, the best data are actually in stable pulmonary fibrosis patients, where there's actually little by way of inflammation that's going on. We are uncertain whether introducing these drugs early, when there's still inflammation that's going on in a COVID-19 patient, would would actually help to mitigate this particular signaling pathway. So we await further studies, but at this point in time, they are probably more investigational and speculative rather than something we would use upfront. So I'd like to conclude by saying that a large number of patients with severe COVID may have potential long-term pulmonary fibrosis, and given the number of the world population that is affected by this condition, we can expect that this is going to be a problem in the next decade or so that we may need to allocate certain healthcare resources to. They are shown to have a decrease in exercise capacity and quality of life that's not entirely explained by lung function impairment, and whether this again is to do with overactivated pro-inflammatory cytokines, we await the studies. And finally, can we mitigate this somewhat? Obviously, preventing severe illness in the form of the monoclonal antibodies and oral pills together with judicious mechanical ventilation is important. Steroids is important, recognizing it can be a double-edged sword, but especially so in the subset of patients with organizing pneumonia. Antifibrotics and mesenchymal stem cells are conceptually attractive, but unlikely to be beneficial at this point. Again, thank Mount Elizabeth Hospital, and also to introduce my team. So the picture that you see on the left is my colleague and myself about to perform a tracheostomy on a patient with severe COVID. These are the 5 doctors in Respiratory Medical Associates. We all respiratory physicians and intensivists, and there's a QR code in case you needed my details. Thank you.
Chan. Our next speaker is Dr. Edgar, an interventional cardiologist with Mount Elizabeth Hospitals. Now, his subspecialty interest includes structural heart diseases, congenital heart, and also pulmonary hypertension. He'll be sharing on COVID and the heart, inflammation, scarring, and arrhythmias, the long road to recovery. So, ladies and gentlemen, let us welcome Dr. Tay, please.
Hello, my name is Dr. Edgar Tay from the Asian Heart and Vascular Center of Singapore. Today I'm delighted to speak to you on this topic on COVID and the heart, especially about the long-term impacts on the cardiovascular system. So COVID is a very heterogeneous condition. When you talk about the heart, it can present with very asymptomatic disease, but it can also present with very severe presentations or phenotypes, for example, acute heart failure, acute myocardial infarction, or even cardiogenic shock. What I want to actually emphasize is that actually if we look at the amount of data that we have, a lot of it is focused on the orange box. But if you look at the majority of patients, they actually fall into the asymptomatic or mild presentation. And we have very little data on this particular group of patients. So really today we're going to explore and try to decipher whether at the end of COVID-19, will all our patients be running and be back to normal? Or will we be burdened with a long-term sequelae of cardiovascular diseases? So before that, let's go through a little bit about COVID and how its impact on the heart is known at the present time. So if you look at this very early set of data, we know that patients that present to the hospital with COVID-19 infections actually have cardiovascular impact. And you can see that at least 50% of these patients will have elevations in their troponin level. There has been postulations on how these mechanisms can occur, and this can go through a process of type 1 myocardial infarction, type 2 MI, or even things like chronic ischemia, stress-induced cardiomyopathy. And these are the typical phenotypes that we have kind of explored or postulated. It has only been pretty recent that imaging has proven that these speculations were correct, in that a significant proportion of patients may present with myocardial injury from myocarditis, some with combinations of ischemic heart disease with myocarditis, and some with ischemic heart disease alone. There are also very unique presentations that have been described. For example, this is known as stress cardiomyopathy or Takotsubo cardiomyopathy. This is really a condition where the patient is under significant stress from an infection and then develops a weakening of the heart muscle. And it's very unique, called Takotsubo, because it looks like the octopus trap that the Japanese fishermen used to trap the octopus. So you can actually see that the shape of the heart resembles this structure.
If you look at the epidemiology, there has been a significant increase in the number of cases of patients with stress cardiomyopathy. Arrhythmias is also a very prominent feature. This is firstly described in the early experience from the Chinese, and up to about 7-8% of patients would have significant arrhythmias, including things like atrial fibrillation, PVCs, atrial ectopics, or more serious conditions like VF or VT. QTC prolongation is something that we see as well, and this typically is related most times to the drugs that we give to patients with COVID-19. Acute myocardial infarction you're all familiar with. There was a bit of a scare initially thinking that a lot of patients with COVID-19 may present with acute myocardial infarction. Yes, there is a signal that the risk is higher. If you look at this data, those between 0 to 7 and those between 8 to 14 days after COVID-19 have a significant risk of developing acute myocardial infarction with COVID-19, but the actual numbers are not that high. Heart failure is also common. If you see patients with COVID-19, if they have pre-existing heart disease, especially if a history of heart failure before, their prognosis is poorer, they are at higher risk of going to the ICU or even having higher risk of mortality. Some can present also with right heart failure, especially those with extensive lung disease or what we call ARDS, or acute PEs that can lead to right heart failure. Some patients may crash and present to us in cardiogenic shock. And there's also another interesting condition that presents like heart failure called the MISA, or multi-system inflammatory syndrome in adults. This is a unique condition typically seen more in the young patients, middle age. They present with fever, some gastrointestinal symptoms, and then they can present suddenly very sick with low blood pressure, poor ejection fraction, and inflammatory markers all being elevated. This is actually a unique subset of patients, but again, not a lot of patients present so sick like this. Venous thromboembolism is something that we have also seen in patients with acute COVID, and these hospitalized patients have a much higher risk of developing clots, say, in their legs, like DVT, or present with acute pulmonary embolism. But this is really the kind of patients that present very dramatically, and you can actually see this classic phenotypes, and we know all the sort of sequelae that follows these conditions. But what we're really interested in today is actually the more common group of patients that we don't really know a lot about. And this is the patients who are less symptomatic and the ones that didn't get into the hospital. What actually happens to these patients? Do we have data on them? So this is where we're going to discuss this condition called the long COVID syndrome. And basically, these are patients who have had COVID. They didn't die. They didn't have very severe disease, and they recovered. And 4 weeks later, they continue to have symptoms which have become a problem for some of them because it affects their quality of life. And so we know that cardiovascular symptoms are very common after what we call recovered COVID patients. So if you look at most studies, dyspnea and chest pain is a pretty common presentation. Some also present with palpitations. And in this particular study, you will see that patients who were hospitalized or had a more significant kind of post-COVID inflammation state actually have more higher risk of developing long COVID cardiovascular symptoms. In fact, patients who are older, females especially, and those with higher body mass index may also have an increased risk of developing cardiovascular long COVID symptoms. And especially those who had to present with a lot more symptoms in the acute phase, they are also more likely to get the long COVID symptoms. As cardiovascular specialists and also primary care specialists, we need to really look at the patient as a whole. We need to also understand that during this pandemic, what has really happened is the patients, some of them have actually neglected also their ability to see the doctors because of the fear of getting to a hospital. So their pre-existing cardiovascular risk may not be well managed. So you need to look at also the other things that can contribute to some of these symptoms, not just COVID, but actually a worsening of their pre-existing cardiovascular problems. But we also have to understand that COVID may have an impact on them. For example, can impact on inflammation of the blood vessels, impact on the risk of thrombus formation. So we need to look at the patient as a whole. We know from basic science that there is actually a lot of significant injury in the microscopic state. And if you look at the cells itself, you can have direct viral damage to the cells. We also know now that actually the virus can actually result in some immune-mediated response that can influence also the autonomic function and lead to autonomic dysfunction. And if there is also fibrosis that occurs at the level of the cells, increased fibroblasts can actually cause this displacement of desmosomal proteins and over time increase the risk of patients getting palpitations or arrhythmias. So in this group of patients, what do we do with them? There is actually some data or some guidance from the athletes, young people who have had COVID, and what to do. Can they go back to sports? So in the patients who are very sick, hospitalized, and very, very ill, there's a very clear pathway and well described that we should really assess them, make sure that they are safe, their troponins have to be normal, their EF has to be normal before they can go back to their sports. And typically that will be a 3 to 6 months period before they can actively go back into sports. So we have a well-defined guideline for this group of patients. But what I want to highlight is really the lack of data in the younger cohort, or the well cohort. We didn't go to the hospital, didn't present so sick. This area of patients, the data is very, very lacking. So if you look at this Frankfurt study, 100 people recovered. They just randomly took this group of patients about 71 days after their COVID infections. They just brought them in, did an MRI scan, did some blood tests, and they found that a lot of them actually have MRI abnormality still at 71 days, and their troponin levels, which is a marker of myocardial cell injury, is still elevated. And in a young group of patients that they just selected, about 23 of them, when they came in, they just did an MRI for them. They didn't have any symptoms. They looked like 15% of them actually met criteria for myocarditis. So the actual virus can affect the heart without the symptoms, and these athletes don't even know about them. So 15% was really a little bit of a shock to the community. So subsequent to that, they did a much larger study. So they're looking at 10,000 athletes now. And actually, when they zoom down to actually how many athletes actually can get this kind of myocarditis, is actually about 2.3%. So not as large as we thought it would be. But what was interesting in this group of study, the athletes were then subsequently followed up and they did the MRIs again after a certain period of time. And you can see that the patients who were actually more symptomatic with the myocarditis presentation tend to have less recovery. And you could still see damage on the MRI. But the patients who are subclinical and really have very little symptoms, a larger proportion of them actually improved. And this is a reassuring set of data. This is probably the latest set of data that actually looked at 6 months later after COVID, comparing a group of patients that had COVID and a group of patients that didn't, and look at the MRI. And actually, in this particular study, the MRIs look fairly identical. So there could be still ongoing kind of early damage, but over time, there could be also recovery. POTS is a unique situation where patients present post-COVID with palpitations, and this typically occurs when a patient stands up, what we call postural orthostatic tachycardia. And this is a unique situation where patients feel very symptomatic when they get out, when they stand up, or sometimes when they do a little bit of work. And so what we have now done is that looked at these patients. There is a registry going on to study these patients, and we found that certain medications like Corolan, beta blockers actually help these patients. But what about the long term? What happens to them over the long term? We really have very little data, but here is where we try to gaze through the crystal ball to try to guess. So number one, we know that troponin elevation in a variety of conditions, not just cardiovascular AMI, even sepsis, can raise troponin. And we know that many studies, as long as troponin is raised, the patient's long-term prognosis is not as good as those who are not. Second thing is that we know that in patients who have previous viral myocarditis before, if their MRI shows abnormality, then the risk of long-term sudden events, for example, cardiac death or arrhythmias, becomes significantly higher. So if the patient gets an MRI and has scar, for example, in the heart, then certainly their prognosis may not be as good as those who don't have a scar in the heart. There's also this concept of thrombus formation in the lungs as well, and this may have a long-term sequelae. This is a study done by one of my good friends in the university, and actually in this NUS, and it found that significant proportion of patients may have thrombosis in the lung arteries, and over time we worry that they could develop into a chronic state, what we call chronic thromboembolic pulmonary hypertension. And this condition, what actually happens is the patient becomes breathless after recovering from an acute episode. So this is something we are keeping our eyes open. And of course, finally, if the lungs are damaged, the right heart always has to pump across a higher pressure. And over time, we also worry a little bit whether there will be an increased risk of right heart failure or right heart dysfunction. Atrial fib is also a concern. We know that in patients previously who have influenza infections, for example, can have atrial myocarditis. And in those conditions, they increase their rate of atrial fib. Fortunately, so far the data suggests that maybe the incidence of AF is not so high. In this 4-week post-COVID recovery patients, the incidence was only about 1%. So maybe not so high at this stage, but what about longer term? This is really something we are looking at as well. And this is my final slide. This actually looks at a very interesting set of data, 150,000 patients from the Veterans Healthcare System. This is really one of the largest group of patients that we have collected data on. So 150,000 patients with COVID-19 from 30 days after COVID to about 1 year at the end, and look and compare them with the historical cohort of patients who have no COVID before. And they actually seen that actually if you look at these patients, especially those who had been sicker, those who have been hospitalized, and those who have entered ICU, they have very much higher risk of developing things like acute myocardial infarction, arrhythmias, strokes. So in this case, for example, the risk of acute coronary syndrome, the hazard ratio is increased to 1.48 in these patients. So this is actually an early insight into the possible high amount of cardiovascular burden in this group of patients. So I'd like to conclude. COVID-19 infection can result in a myriad of acute cardiovascular presentations. The post-COVID-19 cardiovascular outcomes are increasingly reported, but this is just really intermediate term data. Longer term data is still coming on. We still need to follow up these patients before we can know more, but certainly we are looking through this crystal ball and there's already early insights that perhaps some increase in cardiovascular burden may be there. And finally, if we do detect myocardial injury in our patients, we have to be a little bit more careful with them because we know that if there's late gadolinium enhancement, for example, or scarring in the heart, for example, then you really have to think about and discuss with the patients about what is the risk of going further into exercise, for example, and how they have to manage their lives subsequently. So with that, thank you very much.
Thank you, Dr. Tay, for the insightful sharing. And ladies and gentlemen, we're going to get ready our speakers for the panel discussion. And this is where you can get ready your questions for the panel discussion as well. Now for the Q&A, please refer to this. Please post your questions at the bottom of the webinar screen. And also for referrals for your patients to see Mount Elizabeth Hospital's specialists within a day, do use this hotline or WhatsApp. Finally, this event will not be possible without the support of our gold sponsor, Sandoz. Ladies and gentlemen, we've come to the live Q&A of the first session. I'd like to invite Dr. Leong Ho Nam, infectious disease specialist, to moderate our Q&A session together with our speakers from the first session. So let us welcome Dr. Yang, Dr. Chan, and Dr. Tay. Over to you, please, Dr. Leong.
Thank you very much. I must admit, this was really a very exciting talk. 3 eminent speakers, lectures are well delivered, short and crisp. We got the gist of it all. And to remind the audience, keep your questions coming because I get to see them down here. Post your questions to me, and then in turn, I get to ask the eminent speakers. I'm going to start off one, which is coming from Dr. Ling Li Min, and has 4 votes. And it says, thank you, Dr. Yang. Does NCID have a multi-D platform to review those with post-vaccine adverse drug reactions?
Thank you, Dr. Leong, for the question. I mean, one thing I suppose to say first of all is that severe reactions post-COVID vaccination are not common at all. So that some mild reactions, either local or systemic reactions, are quite frequent, particularly following the 3rd dose. But allergic reactions or anaphylactic reactions post-vaccination, unfortunately, very uncommon. We have been working with the rheumatologists, the REI department from Tan Tot Singh, NCID, and we've also been working with SIGN and Prof. Rennie Chi to study people who have had anaphylactic reactions post-COVID vaccination. And it is the allergists at Tan Tot Singh who have been assessing people who have reported an allergy to determine whether they are suitable to receive further doses or whether they should be referred on to the SAM protocol that we have, which is operated out of the Tan Tot Singh vaccination clinic and also at other hospitals as well, and offers Sinovac or Sinopharm as vaccines to people who have a confirmed allergy to the mRNA COVID vaccines. Thank you.
Okay, I know there are on the list, there are actually quite a few questions on long COVID, but I'm going to deliberately hold them back because the next session we're going to talk a little bit about long COVID. Perhaps you let the neurologist talk a little bit more of long COVID before we touch on it, and of course we have our pediatric cardiologist speaking as well. I'm going to go back to the young doctor again, Dr. Yang I meant. Dr. Yang, why do we need vaccination post-COVID infection?
That is a good question. We know that people after COVID develop a strong immune response. Of course, that's partially why some people develop a severe infection, is because of that strong immune response. And that will protect against infections subsequently for a certain duration. So the antibody, the cellular immune responses to infection, which are necessary for resolution of acute COVID, will be able to protect people from being reinfected. We generally think for somewhere around 9 months or so. I mean, obviously this is going to vary. There are some people may develop an infection earlier, but generally we estimate that for around about 9 months, people are likely to be well protected against getting an infection. But the antibody levels will decline. So people will become vulnerable to infection again, and there is the potential that a subsequent infection may be more severe. The immunity from the first infection should help to protect against developing a severe infection, but it's not a guarantee. And receiving one dose of the mRNA vaccines will boost up immunity and really help to provide protection against subsequent infection, and particularly, of course, against getting a severe infection. If I can mention here now, Omicron, which I'm sure we'll be discussing later. Omicron, the early data which is coming out from South Africa suggests that it is a immune escape variant in a way that Delta and the other variants of concern were not particularly. And so that means this this variant is better able to escape pre-existing immunity and cause reinfection. And the best way we have of protecting against that at the moment is by getting a booster, because that will greatly boost up the antibody levels. So if I can continue here, sorry. So we've been conducting a study, which we call Pribivac trial, which is a randomized trial of Pfizer or Moderna vaccines as a booster after the primary vaccine series, and the antibody responses are extraordinary. We're seeing antibody levels be boosted up by 50-fold or even greater within just 1 week after vaccination, and those antibody levels are much higher than even just after the primary vaccine series. I don't know what's going to happen with Omicron, but I think getting a booster will help to provide protection from getting infected and from getting a severe infection.
Dr. Yang, I'm going to catch you on that. Did you say that the risk of infection is quite low in the first 9 months, or is my ears playing trick on me?
Yeah, that's what I said.
Okay.
Yeah. I mean, that's why the MOH have their protocols for not repeated, for exemption from pre-event testing, and for RRT for 9 months post-infection.
Okay.
On the assumption if you pick up something, it's less likely to be a new infection and more likely to be residual virus from the acute infection.
But I'm going to put you on the spot.
Okay.
My job is to put you on the spot, and I'm going to ask you, but will this 9 months, will it still be valid for Omicron? Given that it's an immune escape phenomenon.
Yeah. Okay, I mean, nobody knows. So that's my get out clause. Nobody knows at the moment what's going to happen. I think, so we know that antibody levels will wane after vaccination or after infection. That is a biological inevitability. How much it shortens the duration between which we can expect someone to be vulnerable to reinfection, I don't know. I hope to be optimistic that perhaps what we'll see is people may get infected earlier with Omicron, but they will still be well protected against a severe infection because of their cellular immunity and the memory which will be present. And that memory will persist for a very long period. And that's been shown from several studies that the B cells, the T cells, we have good memory both after vaccination and infection, and that persists to protect people against a severe infection for a long period, even if they may become vulnerable to a mild infection.
I would agree with you. I'm going to stand with you and say that after an infection, after vaccinations, the memory T cells do make a difference. We're going to end up with milder illness. And that's my money. My money is down that Omicron is going to be a little bit milder. That's good for us. It's good for the whole world. Okay, I'm going to give Dr. Yang here a little rest while I jump over to Dr. Kenneth. Colonel Kenneth, you have one question down there about asthma being a risk factor, and I think it's a brilliant question. What do you think?
Okay, so thank you for that question. So in general, respiratory viruses, COVID included, they are not, asthma per se is not a risk factor for acquiring these infections. It's more to do with transmission epidemiology. But having said that, if you have asthma and it's uncontrolled, and if you were to catch an infection, and COVID-19 included, then it's expected that the illness will be more severe because it's now a double whammy, right? You've got a potentially virulent virus plus the effects of an asthma exacerbation. And that's why since COVID-19 there had been guidelines. It's good to impress on your patients to ensure that the asthma is really well controlled, to be diligent and adherent to their medicines. Thank you.
Okay, I agree. Thank you. Anyone, if any questions, feel free. We have a question and answer panel here. Ask your questions because I am eagerly trying to ask my experts down here on my right. I'm going to jump back to Dr. Young again. There is a question that's really quite popular. I lost it there for a while. How would the variants affect our research on treatments?
This is actually somewhere where I think we may have more problems compared with the vaccines. So we've got three basic types of treatments for COVID. We have the small molecule antivirals such as remdesivir, hopefully coming with oral antivirals, molnupiravir and the others. We have the monoclonal antibodies, and we have the immune modulators, corticosteroids, toci, baricitinib and so on. For two of those, I don't think Omicron is going to make a difference. I don't think fundamentally the pathophysiology of COVID-19 is going to change. We've not been detecting problems with resistance to the small molecule antivirals, and there's no evidence that that is going to be a problem with Omicron. The way the host immune system responds to infection with SARS-CoV-2 is not going to fundamentally change either. I mean, hopefully it will be a milder illness, and so we'll have even less requirement for these treatments. Where we may see problems though is with the monoclonal antibodies, and there is some early evidence for that. And this is also not new. So we have sotrivimab and Regencov available in Singapore, but there are other monoclonal antibodies which were granted an EUA by the FDA, but which are generally not used anymore because beta and gamma variants of concern were not well bound by those monoclonal antibodies. And this is a major concern for Omicron. And the next bit says that the people who we use monoclonal antibodies for are the people who are at highest risk of illness. So when we can diagnose COVID early and we can give a monoclonal antibody, we know that we can help prevent severe infection in these individuals. And the people who are at highest risk are those who are unvaccinated, older adults and people with comorbid illnesses. And particularly it's having all three of these together. Vaccination is good in older adults. It does help to protect very well against severe disease, though the risk is still present. But it's really unvaccinated older adults who are going to become more vulnerable potentially because we may not be able to use as an effective monoclonal antibody. So that's where I think we may see some issues with Omicron.
Okay, I agree. The questions on long COVID, I'm deliberately holding them back because we're going to deal with it in the next session, so I'm not trying to ignore you. I'm going to ask the two, Dr. Chan as well as Dr. Edgar here, what do you think of TCM, traditional Chinese medicine, in actually treatment of COVID-19? Well, we heard about the antiviral aspects, but together helping the lungs and helping the heart, what do you think?
Maybe Kenneth, you want to try it?
Okay, so thank you for that question. I actually have no view. I've not seen any research alluding to the use of TCM to treat COVID. So right now, I would say if you're keen to try it, it will be at your own risk. But I guess if you think it's not harmful, it's worthwhile. But right now, any recommended TCM treatments is probably investigational. That's what I would say. Yeah.
I think I share the same opinion. I think the role of TCM, we don't really have a lot of data on that.
Yes.
So I would probably try to steer away because it will complicate, especially post-COVID. I think if you take TCM, sometimes there might be some other, I've seen some patients develop palpitations and some other symptoms from these medications, even not relating that to COVID. So it sometimes masks or complicates symptoms a little bit. So I would steer away from that.
So actually that reminds me, I've come across a letter that's written even to the Prime Minister, hoping to actually put TCM medications to get COVID management as part of the fight, the national fight against the COVID-19. But at this point in time, it's a little bit tricky, isn't it? Barnaby, what do you think?
Yeah, I mean, the majority of people, particularly if they're vaccinated, who develop COVID will develop a mild infection, which just requires symptomatic relief. That may change next year with molnupiravir. But, you know, for now, and since the beginning of the pandemic, fortunately, the majority of people have a relatively mild infection, require symptomatic relief only. If they feel that TCM is able to help with those symptoms, I think that's fine.
Yeah.
But we need to be careful giving it to people who may be at risk for severe illness or at risk for developing any reactions to TCM, which may complicate their COVID.
So could I just sum up that actually we are all open to it, but we'd like to see more evidence. We are concerned about the reactions with other medications which we are using. But otherwise, when the data comes, I think all of us would really love to see TCM come into the market as another means of coping with COVID-19. Okay, I'm going to jump over to Kenneth here. There is a question on about this physiotherapy, singing therapy, mild COVID patients with residual dyspnea. What do you do with these people who have persistent symptoms?
Yeah, so thank you for that question. It's really a cute question. So I will start by making some comments on the basic physiologic principles. First of all, singing especially, there is a little bit of evidence in individuals with chronic lung problems and specifically emphysema or chronic obstructive pulmonary disease. And it's just basically singing forces you to exhale slowly, because to kind of sing a note. And that helps in the physiology of dyspnea in this group of individuals. The second thing I would say, and I would then refer you back to my slides earlier on, is that even the severe COVID patients, they are not really left with a lot of respiratory function impairment. Okay? And even up to 3 months down the road, only a small proportion actually have respiratory function impairment, and it tended to be mild. So the physiology of dyspnea is yet to be elucidated. Whether it's the pro-inflammatory milieu that we've heard about, whether it's steroids or weakness, or whether it's mood issues, which I think you will hear more about in the next section or so, we don't really know. Now, having said that, I guess for want of anything better, singing is harmless. It makes people feel better, so why not? So that would be probably some of my comments. Yeah.
Okay, thank you. Dr. Tay, I'm going to ask you this question, which popped up quite interestingly. Athletes recovered. Do I need an MRI scan?
I think this is a very good question. I think the return to play guidelines have been published by the American College of Cardiology, actually addressing the data that we have more on kind of myocarditis patients. So if patients are typically symptomatic, they've been given diagnosis of myocarditis, certainly those patients who are, say, hospitalized, unwell, they definitely should be evaluated, usually with some form of imaging, so either echocardiography, troponins, perhaps some ECG testing, and even Holters. And they usually would be reviewed for about 3 to 6 months to make sure all these tests are negative before they return to play. When it comes to kind of the patients who are milder outpatient symptoms who have recovered, that data is still not so clear. I would say that if the patient has kind of concerns and it's a very competitive, aggressive kind of sport, and there's significant uncertainty, say if the patient has on basic imaging or basic ECG monitoring has some, say, ectopics that's more than usual or something like that, I would say the threshold to have that information and image would be kind of lowered. So I would say I don't think we can endorse a kind of routine MRI for every single person, but I think it would still be a kind of clinical judgment and assessment for patients who are generally mild. But for the severe symptomatic ones, I think they can consider an MRI to look for scar and edema. Thank you.
Thank you. Okay, I'm going to jump back to Dr. Yang. Okay, can we ever reach herd immunity with COVID-19? From Delta to Omicron and, yep, what do you think?
No. We don't. I mean, unfortunately, it was something that was talked about a lot at the beginning of the pandemic, when there was all the talk about flattening the curve and building up the community immunity, for another way of putting that term. And there was the hope that if enough people got infected and then we got an effective vaccine, that we would reach this magic threshold of herd immunity, of community immunity, where COVID is either eradicated or completely under control. I think with Delta, that very quickly became obvious. It was not possible. Omicron, unfortunately, only adds more weight to the argument that herd immunity is not something that we can achieve. But what we can achieve, I think, is a managed situation. So we certainly can moderate the impact of COVID-19. So with enough people getting vaccinated, and with some level probably of infection in the community as well, we can stop, or we can reduce the chance that healthcare systems will become overwhelmed. So people will get infected. There'll be mild infections in the main, you know, we can get where we can get to is to a place where I think we're living with COVID and where life can go back to something like normal. I thought Delta was the beginning of the end.
So in other words, do you think after Omicron, or when Omicron hits us, eventually we're just going to end up with a simple cough, simple runny nose? And then that could be a mask down thereafter?
A mask down. I hope so. I mean, I don't know, but I don't know where it is. We've got more Greek letters to get through. So I don't know whether Omicron is that sort of, we hope it's the next step to attenuation. To the virus doesn't want to harm us as such. It wants to just, or, you know, its goal, it's driven to infect more people. And Delta was a virus that was clearly much better at transmission, but was not a hard immune escape variant. Omicron, perhaps more immune escape, but is still looking like a very transmissible virus. I think like the other seasonal coronaviruses, that's where COVID-19 is heading. It's just how long it takes to get there.
Kenneth, Edgar, any other comments on this, or your hopes?
No, I agree with Dr. Yang. Typically, as a respiratory physician, our experiences with many of the respiratory pathogens and is that eventually, after a while, you know, the virus will evolve, okay, potentially more transmissible, but probably less virulent, and together with some immunity out there, whether it's natural or through the acquisition of vaccines, it would probably then kind of de-escalate the virus to one of the common upper respiratory tract infections that we see both perennially as well as seasonally. Yep.
Edgar?
Yeah, so I'll just say I'd like to be optimistic. I think we just have to keep our eyes open, learn from Barnaby's data, and then look after our patients well, and I think things will look bright in the future.
Okay, last question. Yes, no answer. People asking, long COVID clinic, can we get a subsidized care from there?
Yes.
Great! Subsidized care for long COVID.
Please.
That's music to my ears. And with that, we're going to end this session of question and answer. We're going to go on next to the next exciting program. Stay tuned. Don't miss out. You miss out, you lose out.